Welcome to the final day of our conference. I'm so thrilled to see the early risers post-gala celebration, and I'm very grateful to our panelists for being here for this session. This session, Prevention, Identification, and Treatment of Post-Surgical Hypoparathyroidism, is supported by an educational grant from Ascendis Pharma. And so we'd like to thank them for their support of the AAES. And I'll welcome Dr. Doug Turner up to the podium to moderate this amazing session. Thank you.
Thank you. Yeah, when we had our pre-meeting, we set up a bunch of poll questions. So those will come up during the session. We wisely made a decision just to postpone the poll questions for a little bit. So seeing the audience now, it was probably a good decision. We also set the agenda and to address hypoparathyroidism, and there's been a little bit of overlap with what came in the session Saturday. So we're just going to play off that, reinforce, and have some fun with that. I'm Doug Turner, professor of surgery at University of Maryland. We have a very distinguished panel here. How do I do the slides? There we go. Jason Prescott, residency at Yale, fellowship at Harvard MGH, worked at Hopkins for a while. Now he's at NYU Langone. TK Pandian, Mayo residency, fellowship also Harvard, at Wake Forest now. Dr. Sonia Khan took her residency at UT Houston along with her fellowship. Sarah Fisher tells me that she was a community endocrinologist. They recruited back to MD Anderson, so she's at MD Anderson now. And Karen Devon, residency at U Toronto, where she returned after fellowship at University of Chicago. So here is our list of talks. As I say, we're going to have some questions merged in, and then time dependent, have some scenarios at the end. So without any further ado, let's get to Dr. Prescott.
Well, good morning, everyone. It's a pleasure to be here this morning. You guys are the hale and hearty. As I get older, and between my family and my job, I have very few opportunities to actually get out at night into the world. And when I do, as I get older, I find that the next day is increasingly difficult to manage. So kudos to you for being here at 7 o'clock in the morning. And it is a real pleasure to talk to you. These are friends, they're family. I've been coming to this meeting for 15 years, and every year that passes, it's that much more exciting to be here. Today, my presentation is going to include some questions, as Dr. Turner mentioned. That's a new technological wriggle for me, so hopefully we won't run into too many problems, but if so, we'll wing it. So again, thank you for being here today. I am going to start by giving a brief introduction to this topic, and some of this is going to be very basic and obvious for you, and some of it will be a little bit different, and we'll talk about a little bit of the controversy that surrounds this diagnosis and some of the challenges that are out there when it comes to defining it to begin with and its various forms. I have one quick disclosure. I serve as a consultant for Johnson & Johnson. That has nothing to do with today's talk. All right, so we will spend all but the briefest amount of time talking about anatomy. Everybody in this room knows where the parathyroid glands live, with a few, really irritating exceptions. I don't think I have a pointer here, but the parathyroid glands are situated on the posterior, superior, and inferior surfaces of the thyroid. There are 4 of them, although again, there are irritating exceptions to this rule, and their localization, actually, as you all know, can be quite variable. It's very important to know the topic we're talking about today is in the context of having undergone previous central neck surgery. We're really going to focus on total thyroidectomy with or without neck dissections, though it's important to know that any extensive bilateral central neck surgery can produce hypoparathyroidism as a result of irritating or damaging the parathyroid glands. It's also important to know from the standpoint of context for diagnosis that this is a biochemical diagnosis. It is not uncommon for me, and I imagine for you as well, to receive consults or questions from referring providers where incidental imaging suggests an enlarged parathyroid gland and biochemistry is entirely normal. That's not hyperparathyroidism, and those folks do not require surgery. So the biochemistry is where the diagnosis comes from, and the imaging is really secondary and only for purposes of surgical planning. So what is the biochemistry? How do we define this diagnosis? And we'll talk about this because it's actually somewhat controversial. But if you look at our own guidelines and those of the ATA, you'll see that it's a low or inappropriately normal blood parathyroid hormone level after central neck surgery in the context of hypocalcemia. That's it. It's not really so confusing if the biochemistry shows a low hypoparathyroid hormone level and a low calcium level, then this diagnosis is going to be present. And we'll talk about when there is low calcium and normal parathyroid, or low parathyroid hormone levels and normal calcium levels. This is where it starts to get a little trickier. It's also important to know that this diagnosis varies in its symptomatology. We'll talk about symptoms in a moment, but by no means are symptoms uniform. And when they happen can be a little confusing as well, the timing postoperatively. So the nadir of calcium, blood calcium after surgery, central neck surgery, is somewhere between 24 and 72 hours, but that doesn't necessarily reflect when symptoms will develop. So what about symptoms? Symptoms are somewhat vague. You can fall back on some basic commonalities when it comes to symptoms. And these are things like numbness and tingling. The way I describe this to my patients is it's like when you fall asleep on your arm wrong and you get pins and needles in your fingers. It can be in the toes, feet, around the mouth and the face. Sometimes muscle spasms accompany this, and those are reliable symptoms of hypocalcemia. But then there are odd ones. There are neuropsychiatric symptoms like irritation and anger and depression, sometimes confusion. The strangest one I ever saw was actually about a month after surgery. It was just bizarre, and her only presenting symptom was burning leg pain at night when she went to sleep. And when she called me with this, and I said, well, that can't be low calcium and parathyroid hormone, but let's check it anyway. And her calcium level was 6.5, and we fixed it. Those symptoms went away. So have a low threshold to look for strange presentation when it comes to hypoparathyroidism in your postoperative patients. Signs. So there are two main signs that we look for when it comes to this. The first is Schwastek sign. Let's see if we can get the video to work. That's the image for you on the left side. This is when you tap the distribution of the facial nerve and you have that spasm. Oops. Can we start that video again? Would that be possible? You can see the sides of this woman's mouth spasm as they tap there. That's Schwastek sign. Schwastek sign is a sign of low calcium, low magnesium as well. It's not very sensitive. Well, it's not very specific. About 25% of the population will have this at baseline with a normal calcium level. The next one, though, this is Trousseau's sign. That's this hand finding. You mind playing that for me if you can? This is the hand. Yeah. So these are involuntary movements in a patient with low calcium. And what you do is inflate a blood pressure cuff. You bring that to a pressure greater than the systolic pressure. And then you hold it there for 3 minutes. And what that does is it causes wrist flexion, metacarpal flexion, finger extension and adduction in this very prototypical way. And it's involuntary. And you can see there that this gentleman was trying to force his fingers back into their normal distribution and couldn't do it. So that is about 94% sensitive. That being said, again, most of the time we have the biochemistry for this. So these signs are more just of interest rather than used for diagnostic purposes. Okay, so we're going to do a quick audience poll. We'll see how this works. I just told you about the biochemical diagnosis of hypoparathyroidism, and that should make it fairly straightforward for us to determine the incidence of this particular problem. So I'm going to ask the audience, we're going to talk about estimation of true hypoparathyroidism incidence in the United States is confounded by which factors? Do we have the question itself? And if not, we'll go through it. It's a multiple choice question. That's all right, we'll come back to it. You can just bring the presentation back up, please, if you would. We'll just continue through. Okay, so it turns out actually that incidence is difficult to estimate, and it's challenging, therefore, to kind of get an idea of the shape of this problem after surgery. If you go into the literature, you're going to see an estimated incidence somewhere between 19 and 38% after total thyroidectomy. It varies a lot, and that includes both temporary and permanent hypoparathyroidism. We'll go through the reasons why that's the case, but the bottom line is that different places define this somewhat differently. Not everybody reports it, and there are differences in the overall experience of the people that are doing parathyroidectomy when it comes to defining this as well. And as you all know, the more of central neck surgery you do, the more thyroid surgery you do, the lower your complication rates will be. And so this includes a lot of providers that perform relatively few of this surgery, relatively little of this surgery every year. And so it will vary dramatically between providers. Temporary versus permanent hypoparathyroidism is a very important subject. All of you will encounter this. Temporary, certainly, but if you do this long enough, you will have patients that will develop permanent hypoparathyroidism, which can be quite debilitating, as you'll hear as we move forward through these talks. So how is this defined? Well, when I began practice a long time ago, it was that 6-month marker after central neck surgery. When you checked it at 6 months, if the biochemical diagnosis was still there, then this was considered permanent. There's some controversy about this now. In fact, one of our own summit groups has changed this definition a little bit, and that has to do with data that say that the parathyroid glands in temporary hypoparathyroidism may actually recover up to a year or a little bit further out from surgery. So if your biochemistry remains abnormal at 6 months, that doesn't necessarily mean it's going to be permanent. The probability, though, that it will be a permanent problem every day that passes after that surgery increases. And then briefly, the physiology of hypoparathyroidism. So parathyroid hormone, as you know, does a lot of different things. Its main organs of interest or action are the bone, the gut, and the kidney, where it functions to maximize the calcium content of the body. All right. So here we are. This is that question. So let's do an audience poll, see if we can get this to work. Which of the following are established risk factors for the development of hypoparathyroidism following bilateral surgery? So the QR code is there. Let's see if we can get some answers for this. We'll give it a moment. Everybody ready? Give it a second more. All right, we'll go to the next slide. Okay. And let me see. And I apologize because this isn't all showing up. There's also hopefully it's not showing up on your phone. There's also an all of the above option. It's there. Oh, there it is. Okay, perfect. Got it. Perfect. Wow, wow, exciting. I don't have my 18-year-old here who manages all technological problems for me. All right. So the answer is all of the above. There are many, many, many risk factors for hypoparathyroidism out there. We'll go through them briefly. So what are those risk factors? These are probably the 12 most obvious. All of them can contribute to the risk of developing postoperative hypoparathyroidism. The ones that particularly stand out in terms of odds ratio are hypomagnesemia, which has about a 2.85 odds ratio of developing hypoparathyroidism, vitamin D deficiency, which comes in at about 2.32. And then previous bariatric or gastric surgery is also important, and we'll hear probably a little more about that as we're going through today's conversation. And the odds ratio for that's about 3.9 for folks who have undergone previous bariatric surgery or gastric surgery. All of the others, though, fall into this category and are worth considering when you're thinking about hypoparathyroidism risk in your own patients after thyroid surgery. Some of them obviously are modifiable, some of them are not, and they vary in terms of how significant they are, but all worth considering. All right. What about parathyroid autotransplantation? So if you looked at that last slide, parathyroid autotransplantation is associated with a risk of hypoparathyroidism. Is that permanent or temporary? Audience thoughts? Oh, interesting. Okay, moving around a little bit. All right. So you might think that parathyroid autotransplantation is associated with permanent hypoparathyroidism. It actually is not. So it's certainly associated with temporary hypoparathyroidism, but not with permanent. So if you're autotransplanting a parathyroid gland, that's not going to increase your risk of having permanent hypoparathyroidism postoperatively for your patient. All right. What about magnification surgical loops? So I do want to talk about this because I found these data to be actually very interesting. If you use magnification, that's me and actually our very first NYU fellow operating together during parathyroid surgery, and our anesthesiologist getting into the view as well. We always use surgical loops, and the reason for this is the data are actually quite good for both inadvertent parathyroid gland resection during surgery and also risk of hypocalcemia, both biochemical and clinical postoperatively. So the odds ratio, for example, if you use loops for inadvertently removing a parathyroid gland during thyroid surgery is about 3.8. If you don't, it's about 7.8. The risk of biochemical hypocalcemia is about 20%. Looking at all the data, if you're wearing loops, it's about 30% if you're not wearing loops. So there are good data that are well designed and with very good statistical analysis that say that magnification helps with this if you use it. All right. And I'm going to leave it there and move on to the next group so that I don't shortchange anybody, but we'll have an opportunity to talk more as the panel gets warmed up and your questions at the end are addressed, and I look forward to talking to you. So thank you very much for your time, and I look forward to the questions at the end of the session.
Thanks, Jason. Gina, if you didn't get my text, we're going to skip my poll questions and go right to Dr. Pandian's just to get through. So I had a bunch of poll questions. If time permitting, we could get to those at the end. But if you heard the UAB results of their questionnaire, a lot of them were we've answered already and heard about some of those answers already. So next, Dr. T.K. Pandian is going to talk to us about strategies and adjuncts to avoid hypoparathyroidism.
All right. Good morning. Thanks, Dr. Turner. I'll start by saying this is not a comprehensive list of tips and tricks. Certainly, we've heard a lot already at this conference. Those of you that attended the thyroidectomy, how I do it session on Saturday heard some of these things, and so I'll reiterate those and talk about a few other things as well. We'll talk a little bit about autofluorescence and ICG, and then I'll also talk a little bit about some of the technical considerations in parathyroid surgery. As you all know, patients with multigland parathyroid disease can also have permanent hypoparathyroidism post-op. And then I'll briefly mention cryopreservation. I know that's always a little bit of a hot topic at this conference. So starting with the technical aspects, I think I always think about Dr. Hoden from my fellowship time talking about the capsular dissection. I do think that's very helpful, and really the rationale for this is to prevent damage to the terminal branches of the inferior thyroid artery, which we know supply the blood to the parathyroid. So staying as high as possible, always not possible in some cases, especially in chronic inflammation and cancers, et cetera. But staying as sort of high as possible on the gland during the dissection helps with that. Over the years, I've had a lower threshold to leave a little bit of remnant thyroid, especially near the ligament berry, and sometimes even at the inferior pole, depending on the lay of the parathyroid, so especially for glands that are a little bit more intracapsular. Obviously, for benign disease, it's not a big deal. For cancers and other things, try not to do that as much, but that's certainly an adjunct you can use. Leaving behind a little bit of thyroid is not a bad thing. In terms of central neck dissection, Dr. Prescott mentioned that's one of the risk factors for developing hypoparathyroidism, so being thoughtful about who you perform central neck dissections in. Certainly in cancer cases, obviously it makes sense, but trying to limit that to one side if possible, and just being really aware of those lower parathyroids if possible. It's very hard to save those glands in a central neck dissection. And then early on, I used a lot of frozen section to sort of, amass in my own brain sort of, iterations of what normal parathyroid look like. I think as a junior faculty member, that was important to sort of understand, okay, this is another variation of what a normal parathyroid looks like that's confirmed with frozen section or even a PTH aspirate. So those are all some things that you can consider. In terms of specific patient populations, Hashimoto disease is probably my most scary in terms of in terms of operations, and I sort of say try to avoid it if you can, as long as you can. But obviously there are cases where you need to do that. But just being even more thoughtful in those patients because it's very hard to visualize parathyroids with the chronic inflammation and reactive nodes and everything else. Venous congestion, sometimes you see a gland after dissection that sort of plumps up and becomes purple, and you say, is that ischemic? Is it just congested from the manipulation? A couple of my mentors, suggested taking a knife or a needle and sort of relieving that congestion by sort of just gently cutting the gland, and sometimes that allows the gland to pink up. So that's a tool you can sometimes use to help perfusion. And then autotransplantation, I think, as Dr. Prescott mentioned as well, important if you're confident that a gland is not viable, go ahead and autotransplant it. And used to take that out and put it in saline and do it at the end of the case, but these days I sort of do it as I go. So if I'm on one side of the thyroid and it's very clear that a gland is dead, just sort of go ahead and put that in the sternocleidomastoid right away just to save some additional time. Other things to consider, now data on some of these things is mixed, so you're going to find studies that support and refute, but perioperative steroids have been shown to potentially reduce the incidence of hypocalcemia, hypoparathyroidism post-op. Unclear the mechanism of this, probably something to do with reducing edema, but a dose of dexamethasone 8 milligrams, before the case has been shown to potentially be helpful. In Graves' disease, potassium iodide or Lugol's, sort of reducing that gland vascularity, allowing for better visualization of the gland and parathyroids sometimes can be helpful. And this isn't really a way to prevent hypoparathyroidism, but sort of assessing that patient to see if they might be someone that has that is the use of intraoperative PTH. So checking a PTH at the conclusion of your thyroidectomy, either in the operating room or within a few hours in the PACU to help guide your potential treatment related to potential hypoparathyroidism. Those are all adjuncts to think about. Transitioning to autofluorescence technologies, I think probably the two most common ones you've all heard about, PTI and FluoBeam. I think the Fluo Optics people were here at the conference, but really this is a way to aid in parathyroid identification, especially in difficult cases, for example, Hashimoto's or even Graves'. Overall, the studies are pretty promising in terms of the accuracy in identifying parathyroids, and that hopefully then allows your dissection to be guided a little bit better by knowing where they are. And then there's a little bit of question about does it actually reduce the ultimate rates of postoperative hypoparathyroidism? You can find studies that kind of show both things, but it's another adjunct to help you understand the location and how you might be able to save the blood supply. In terms of viability, ICG angiography has been shown to be very helpful, and really just looking at the perfusion patterns within a parathyroid to help decide, is it adequately perfused? Should I autotransplant it? And some of the studies would show that even if you find at least one or two well-perfused parathyroids after thyroidectomy, you may actually be able to negate putting that patient on postoperative calcium supplementation or even check a PTH. So these are all, again, things to think about in your armamentarium. Transitioning a little bit to parathyroidectomy, a lot of things to think about here, but really what I'm talking about is disease that's multi-gland in nature, so either primary hyperparathyroidism is multi-gland or MEN1 patients, or just sporadic patients that have multi-gland disease, and then, of course, secondary and tertiary hyperparathyroidism. And the question in my mind always when I do these cases is, what is the appropriate volume of parathyroid tissue to leave behind for this particular patient? And I do think it's different depending on the reason you're doing the surgery and patient factors. So I think about the age, of course. My older patients, I tend to be a little less aggressive with a subtotal parathyroidectomy. I think about compliance. A lot of our patients in North Carolina come from rural areas that may not have access to labs. And how will they do if I need to check frequent labs, and will they follow my instructions in terms of calcium and calcitriol? So these are all things I think about as I sort of decide how much parathyroid tissue to remove. And then, of course, if it's a secondary patient, what is their potential for renal transplantation? You might be more aggressive if they are not a candidate for renal transplantation as opposed to if they are, in terms of the amount of tissue that you remove and balancing that with recurrent or persistent disease. So some of the technical aspects, one of the, I think, a general surgery principle for trainees here that are thinking about the oral boards, if you have a case of multi-gland disease, fashion the remnant first so that you can then have some time as you remove the other glands to decide if that remnant is going to be viable. This little drawing just sort of shows, thinking about not all parathyroids look like this, I know that, but if you can get it onto a nice pedicle or you have it on a pedicle like this, thinking about where the vascular blood supply is coming and taking your tissue distal to that. Some people have described using ICG angiography to assess this, and you can actually see the vessels coming onto the gland, and then you can take your tissue sort of distal to that. There's a lot of data out there on how much tissue to leave behind. In primary hyperparathyroidism, most of the literature would suggest 30 to 50 milligrams. Sort of a nebulous thing, frankly, I think, for all of us. What does that exactly mean? Is that the size of a normal parathyroid, slightly bigger? What you feel is a normal parathyroid may be slightly different than what I feel, so I think there's a little bit of experience in it, things like that go into that. But 30 to 50 milligrams for primary, and then for secondary and tertiary, maybe a little bit bigger, just because of the potential bone hunger and other things that those patients experience. Intraoperative PTH can be a nice tool to help you guide how much parathyroid tissue you've removed in a subtotal parathyroidectomy, using maybe the modified Miami criteria for primary hyperparathyroidism. And then for secondary and tertiary, it can be a little bit more unreliable, as you know, because of the renal disease. But some of the literature would suggest maybe a higher threshold for this, maybe on the order of 100 to 150 for your PTH. And then even in these cases, I think thinking about autotransplantation, either in the immediate period, meaning, for example, if you do end up doing a total parathyroidectomy, certainly thinking about immediate autotransplantation. Several groups have described delayed autotransplantation, saving some of the parathyroid tissue in a perioperative refrigerator overnight, checking a PTH the next day, allowing several half-lives, 12 hours or more, to decide if a patient might become hypoparathyroid afterwards, and then going back and reimplanting either at the bedside or in the operating room. So those are all adjuncts to think about. And then finally, parathyroid cryopreservation, the idea behind this is really allowing sort of the remnant parathyroid tissue to declare itself and to understand what its function is going to be, balancing that with the potential for persistent or recurrent disease. And so, as you all know, very few centers do this. At my previous job at WashU, we did have this available to us. I know not a lot of sites do. Dr. Siprenstein and the Cleveland Clinic Group has, written about this in terms of setting it up if you're interested in it. But essentially, it's storing the parathyroid tissue by gradual cooling to a very, very low temperature. And then potentially you have up to 2 years to reimplant, although most studies would show that within 6 months or just around 6 months is probably the best time, and you lose viability the further out you go. And then graft function has been shown to be sort of variable, somewhere between 50 to 60%, although it did see studies as high as 80 or 90%. So this is another potential adjunct to consider. Cost is always something that comes up with this, a lot of resource-intensive needs related to setting up cryopreservation, although we looked at the cost recently, and it does seem to be cost-effective compared to the potential treatment related to severe hypoparathyroidism. So I'll stop there, and Dr. Turner, take over.
Okay, so now you've got hypoparathyroidism. What do you do now? For now, let's call on Dr. Sonia Khan, who will help us manage it.
All right, good morning. So thank you so much for inviting me to come here to speak. It's nice to be in a cooler city as well. I'm from Texas, so it's already quite hot there. So I have no relevant disclosures, and just something about myself is whenever I go to a new place, I always try to go to wherever the local mountains are, the closest mountains. And since I'm not able to do that this time, I thought I'd bring them to the presentation. So this is Nepal on a recent trip that my husband and I took. All right. So what are we looking for in post-surgical hypoparathyroidism? So two main things. We're looking at the labs and we're looking at the symptoms of the patient. So when we're looking at labs, what are the labs that we're looking for? So of course, everybody here knows this: calcium, albumin, PTH, magnesium, and phosphorus. Something important to always remember when we're looking at serum calcium is to use your corrected calcium. And so a little math there: your corrected calcium is your measured calcium plus 0.8 times 4 minus your serum albumin. You can use ionized calcium, but it really depends on where you are. Depends on your center, if it's reliable at your center. In most big institutions, it is. But, you know, as Dr. Turner was mentioning, I was a community endocrinologist. So I worked in Clear Lake, which is outside of Houston, for many years. And at that time, our ionized calcium was not as reliable. And some of the reasons that can happen, some pitfalls, is it's pH dependent. You can have, if you uncap the tube for too long, you can actually have CO2 release. It alkalinizes the blood, and so the actual measured calcium decreases. Incorrect tube type, though I don't think that happens as much anymore. And then temperature sensitivity, and of course, cost. And as we were also talking about people traveling for labs, so we have a lot at MD Anderson, we have a lot of patients that travel for labs. So let's say that you're discharging a patient and you want them to do labs in a week. Well, your ionized calcium may be very reliable, but wherever they're getting it, it may not be. So recognizing that when you're getting labs post-discharge is really important. And then second would be prompt recognition of symptoms, right? Okay, so this is a table that was in the ATA guidelines about, you know, looking at the calcium and looking at the symptoms and what potential you would start for patients. And this didn't really change much in the new guidelines that came out, or it did not change in the new guidelines that came out. And so basically, when you're looking at mild to moderate hypoparathyroidism, you're looking at calcium about less than 8.5, a patient with new onset symptoms that may be mild, or they may be slightly asymptomatic. And at that time, you would use calcium and calcitriol. Remember, whenever it says calcium, we're talking about elemental calcium. If you think about calcium carbonate, that's 40% elemental calcium. Calcium citrate is 21% elemental calcium. If the patient has a calcium less than 7, then you're talking about severe hypoparathyroidism, and they may have persistent or severe symptoms. So at that point, you're talking about PO calcium, calcitriol, and then IV calcium as well. So when we're talking about that third one there, that acute management of severe hypocalcemia, so you're talking about calcium less than 7, and in some places like Up to Date, they say 7.5, and they have persistent or severe symptoms, which we just talked about a lot of the neurologic ones that you see. So we're quite familiar with our patients having paresthesias around the perioral area, the tongue, carpopedal-spasm, Schwachschild-Stein, Trousseau sign. They can have seizures. They can also have laryngospasm, bronchospasm, and then more severe cardiovascular signs and symptoms like bradycardia, impaired cardiac contractility, and then prolongation of the QT. So really looking at what is my calcium? What are the symptoms that the patient is presenting with? And then what do we do about that? So number one is going to be your bolus infusion. So first you'll start with 1 amp of calcium gluconate. You can give it over 10 minutes. You can repeat that every 10 to 60 minutes if needed to resolve the symptoms. That'll raise your calcium for about 2 to 3 hours. At the same time, you want to prep a slow infusion of calcium, which is usually 10 amps of calcium gluconate in normal saline or D5W, and then that'll provide a final volume of 1 liter. You can infuse that at 50 to 100 cc's an hour. And then you should be getting labs every 4 to 6 hours to adjust the rate. You can infuse it slower, just depending on your comfort level. I see a lot of us will usually start around 25 cc's an hour, but this is, it's anywhere from 25 to 100 cc's an hour. You also want to start some PO calcium for them. So if the patient can take PO, of course, and that's going to be elemental calcium and calcitriol. And again, remembering that when we're talking about elemental calcium, when you're doing calcium carbonates, that 40% of that is elemental and citrate is 21%. You want to make sure that you're also correcting electrolyte deficiencies. So if your patient has hypomagnesemia, you want to correct that as well. That can decrease PTH and cause a PTH resistance. So if your serum level is below 2, you can give 2 grams of mag sulfate over 2 hours. If it still continues to be low, you can start some oral magnesium oxide if the patient, of course, is taking PO, 400 to 500, depending on what you have there, tablets, 1 to 2 tablets daily or BID, depending on what you need. If the patient's on TPN, mag oxide doesn't really crush really well, so you can change it to mag sulfate for those patients. And then if they have a low vitamin D, so if their 25-hydroxy vitamin D is low, you can give them 50,000 international units there in the hospital and then continue that weekly outpatient, or you can transition them to an oral, transition them to a over-the-counter daily vitamin D. So of course, this has probably been talked about the whole conference. Early post-op PTH levels are the most reliable predictors of hypoparathyroidism. There have been several different values noted in the literature. So if the PTH is greater than 10 at 12 to 24 hours post-surgery, that virtually excludes chronic hypoparathyroidism. That was noted. In ATA, they say a PTH less than 15, measured at greater than or equal to 20 minutes or 4 to 6 hours post-thyroidectomy, predicts increased risk of acute hypoparathyroidism and warrants close monitoring. And then in some places, you find PTH less than 10 at 6 hours post-surgery, predicts both transient and permanent hypoparathyroidism with high sensitivity and specificity. But generally, in the patients that have the post-op hypocalcemia, it's still a favorable prognosis. So about 75% of those patients will resolve within 6 months, and as we know, it can be up to 12 months and even a little bit more than that. And 25% will likely develop permanent disease and face some long-term morbidity, particularly with renal and cardiovascular complications. So what happens on discharge? So generally, if someone has a low PTH, like we said, less than 15, a low calcium, or a low ionized calcium if you're using that, they should be being discharged on postoperative calcium supplementation. And then what do you do afterwards? So once you're discharging them, depending on how stable their calcium was in the hospital, you can check labs at 3 days or 1 week post-discharge, and then weekly after that as needed. And as I like to say at MD Anderson, coming from the community, we're really spoiled because we get our labs really very quickly. But when you're having labs done for a patient at Quest or LabCorp, they're going to take a little bit longer. So just keeping that in mind when we're ordering these labs when we actually want them. If the PTH is increasing on those labs, you can then drop your calcium and calcitriol respectively. And then if your calcium is going up, especially greater than 8.5, you want to also drop your calcium and calcitriol and then repeat it weekly or as needed. What happens when they develop permanent hypoparathyroidism? So you definitely want them on a calcium supplementation, but you want to go to a goal of 8 to 8.5. You don't want to have that goal higher because then they will have hypercalciuria, okay, and the patient will have other complications. So our goal is about 8 to 8.5, and again, the mention of elemental calcium, and then they would be on calcitriol as well. Magnesium, most patients don't end up needing oral magnesium long term. Usually that's something that we find in the hospital, but if they do or if they have some reason to have malabsorption, we have several patients with different GI cancers. You may need to supplement their magnesium as well. So keeping an eye on that if you're having a difficult time getting them to goal. Making sure that their vitamin D, the 25-hydroxy vitamin D level is also treated and appropriate. So now we know about calcium, we know about calcitriol. When do we consider PTH analogs? And I really don't look to these until really at that year mark. Sometimes we'll look at it a little bit earlier at that 6-month mark. We try to really get the patient stabilized on calcium and calcitriol. But if they're having a high pill burden, the patient is, we have a lot of patients who are in school, who are at work, they can't take their calcium. They're having to take it 3 times a day to really maintain a normal calcium. That's a reason to consider a PTH analog. If they're having wide calcium fluctuations because they're just not absorbing well, or really adherence, which is the main thing, that's another reason to consider a PTH analog. If they're having persistent symptoms, so their calcium is normal, but they're still having a lot of symptoms, they're sending you MyChart messages about oral numbness, having to take a bunch of Tums or calcium to get rid of those symptoms, that's another reason. And then, of course, malabsorption if they're not able to absorb those supplements. So what's available right now? Right now, we have pegteriparatide, which is our PTH-134 Yorvipath. That was approved in 2024. And then previously available, if you guys remember, was the PTH-184, which is Natpara, but that was discontinued. So that was taken off the market because there were some issues with the plunger. And you could get it for an additional, it was taken off the market in 2024, but you could get it up until December of 2025 through a special program. But now with Yorvipath, virtually we don't have any patients. I think we may have one that was getting Natpara up until recently. So how do you dose Yorvipath? So the initial dose is at 18 micrograms sub-Q daily. And if it's okay with you guys, I'll call it Yorvipath instead of pegteriparatide. There's a good chart in the PI in the package insert and also on UpToDate actually of how to dose adjust. So it's really easy. It really takes you step by step. You'll start the Yorvipath at 18 micrograms daily, and then it will tell you, according to the chart, how to adjust your calcitriol, how to adjust your calcium. And then you can increase it in doses by 3 micrograms daily to a maximum of 30. And then as you're going through and checking these labs weekly to every 2 weeks to monthly, it'll actually guide you through how to adjust the calcium and calcitriol. So remember, the patient is on calcium and calcitriol, and then on top of that, you're starting the Yorvipath and then adjusting those supplements down. So this is really step-by-step process of how to do that. So missed or delayed doses, even the insert tells you that. If it's less than 12 hours, that's a daily drug, you'll administer the missed dose ASAP. If it's more than 12 hours, then you'll skip that dose and resume the next one. If the patient's been off of it for more than 3 days, then you can evaluate for signs and symptoms of hypocalcemia. You may need to adjust up their calcium and calcitriol and then recheck labs soon. So what's in the pipeline? This is exciting. So Encalaret is in the pipeline. It's an oral formulation. It works as at the level of the CASR, the calcium sensing receptor. So it's a negative allosteric modulator of the calcium sensing receptor. And it basically corrects the calcium imbalance through increasing reabsorption at the level of the kidney. The great thing is, number one, we'll have another drug to treat these patients who live with this lifelong disease. And number two, it's oral. So we should be seeing some good data from this medication in the coming year. So that's very exciting that we'll have something else to offer our patients. So this is what I have for you guys today. I will hand it over to our next panelist.
Okay, and so our last speaker, Dr. Karen Devon, going to talk to us about parathyroid allotransplantation. Dr. Devon.
Thank you so much. I'm delighted to be able to share our experience today. I love that the media exaggerates sometimes, and so I'm going to talk to you about our miracle transplant. This is actually our patient, and I'm at the University of Toronto. This started with a dirty word. Oh, there we go, Facebook. So I am a full-time academic endocrine surgeon. However, my research is in a completely different area. So parathyroid specifically was an area of interest, but not an area that I was studying in the lab or anything like that. And so I was on a Canadian physician moms group on Facebook when an endocrinologist from another city posted about a patient who was looking around for a parathyroid transplant. And another endocrinologist who I work with tagged me in the post and said, maybe Karen can help. And I said, probably not, but I'll talk to the patient. And the patient came to me with this paper in hand, a publication from Germany, where someone had received, a 32-year-old woman had received a living donor transplant from an ABO-compatible living donor and was doing well. So this is our patient, a 43-year-old woman. I'm going to go through these very quickly because there's quite a lot to cover, and I want to just leave some opportunity at the end. We can always delve into whichever aspects are more interesting. But a 43-year-old woman with 4 children, a police officer. I didn't do this surgery. But obviously the indications for completion thyroidectomy in this patient are questionable. She had 3 parathyroids removed and ultimately was admitted postoperatively. This is back in 2012 for a week due to hypocalcemia. Readmitted again for severe hypocalcemia and responded to teriparatide at the time, and then had just years and years of terrible complications. And they started her off-label with a CAD pump on a continuous teriparatide infusion. And it worked for a while, but I guess there were concerns about that, understandably. And so she came off of that in 2016. And again, just many, many complications. And when I saw her, she was taking 28 grams of calcium per day, 24 grams of magnesium, 8 micrograms of calcitriol and hydrochlorothiazide, and still requiring infusions probably every 9 to 14 days. And she was a police officer. They wouldn't even check her calcium anymore. She would just go to the ER, say, I know I need it now, and through the back door. And so it was quite debilitating for her life. She couldn't work. She had all of these complications in the course of all that time. So this is really like a very, very severe case. I apologize, these are Canadian units. If you multiply calcium by 4, you get milligrams per deciliter. But again, this is on all of her medication. The calcium of 2.13, which is about 8.5, would be right after an infusion of IV calcium. And her PTH was detectable, just not particularly functioning for her. So that PTH is times 10, so that would be like 11, for example. So I saw her. I said, I happen to work at the Ajmera Transplant Center, or at my institution is the Ajmera Transplant Center, which is very well regarded in Canada and around the world. And so let me look into it. And I found this paper from 1911, which I think is the first parathyroid allotransplant. And it's so interesting how they wrote papers back then, because the author first spoke about how people were so skeptical that this organ could be important. And so he says, quote, without in any way wishing to exonerate myself from the blame due to a faulty judgment, that it was owing to such skeptical utterances on the part of some prominent surgeons that this present story is there to tell, with its disagreeable experiences to both my patient and myself. He describes a 24-year-old woman who had surgery for Graves' disease and 4 days later developed tetany. He went to the abattoir and obtained and installed ox parathyroids, which worked for a few weeks. He then got dog, then monkey. He had to use chloroform to anesthetize a patient. She was cramping so badly, so it was just for the pain that he would anesthetize her. And finally, after many months of this back and forth, he was able to get a fresh cadaveric human parathyroid, after which she apparently did well. So he concludes, but the chance for human transplantation seemed too good to be a lost offering, a still stronger hope of happily terminating a most distressing case. There were 3 systematic reviews published around this time. So after we had already, created our protocol and gone through this, the most comprehensive of which is Dr. Lindemann as senior author here in 2021. And they found a total of 148 related patients in case reports and series, and there was significant heterogeneity in techniques, transplant locations, and patient outcomes. And they divided the patients into the recipients into immunosuppression naive recipients and those who were already on immunosuppression. So that is this slide is the people who were already getting immunosuppression, mostly case reports and kidney transplant recipients with live donors from the same donor. There was one neurologically deceased donor, and the best outcome here was of a graft survival 13 years later. And then if you look at the remaining cases, I guess this chart turned out pretty small, but all the remaining cases in immunosuppression naive patients, the 4th column shows that most of this research has been done using cryopreserved tissue. Only 2 of the fresh tissue transplants used normocellular tissue rather than tissue that had been removed for hyperparathyroidism. That's 2 columns over. And the donor tissue type, deceased, was used twice. And really only 1 case in Turkey in 2020 used normocellular tissue from a deceased donor. When I was looking into this for the patient, I also found this paper by Dr. Wells in 1975, and it's mostly a study of autotransplantation, but hidden in there, there was one allo transplant, and amazingly, I texted an email at the NIH for Dr. Wells, and he called me immediately. It was amazing, and told me that patient's graft eventually failed, and that he thought that this was potentially a good idea. Also, patients' views had already been surveyed back in 2018, 252 patients. The summary is basically about 14–15% of these patients with severe disease would consider an invasive procedure, and some of them would give up about 3.6 years of life in order to have a better quality of life. And so I went to Dr. Hatul Humar, who was the head of the Ajmera Transplant Center at the time, and told him this story, and he said, we have an obligation to help this patient, and introduced me to Dr. Catherine Tinkham, who happens to be one of the world experts on tissue and HLA and transplant, which was lucky for our team that we assembled. And we basically created a protocol, a lot of it loosely based on kidney transplant, as the allogeneic potential of parathyroid seems to be similar to solid organs. We had a very standard transplant workup. We obviously discussed risks of immunosuppression. We had to go through various regulatory processes at the hospital, Health Canada, our organ procurement network. So we had a great team. And of course, with the patient, shared decision-making around all the unknowns. There was deceased donor criteria. Many of these are standard for transplant, but we excluded patients who had had previous parathyroidectomy or thyroidectomy, as well as those with chronic renal failure and hypercalcemia. I'm going to skip this. We call it alphabet soup. It's complicated. However, our patient, who had had 4 pregnancies, was sensitized to most of the population, 98%. And so the transplant people were like, it's going to take years for us to find a donor for this patient. And so one pandemic and one maternity leave for me later, we did find a first donor. I won't go into it. The first trial of this for this patient failed. And then again, just for the interest of time, we kind of reassessed and we tried again. And this donor actually had some historical antibodies to class 2. Again, it's this alphabet soup. And we went and retrieved 4 healthy parathyroids from a neurologically deceased donor. My colleagues in transplantation let us go first before all the other stuff was being taken out. And we drove the parathyroid transplant, the parathyroids 2.5 hours from London, Ontario to Toronto. She got induction immunosuppression and ongoing immunosuppression, was discharged from hospital 48 hours later. On all the medications that she came in on, we did not change her calcium, and there were no surgical complications. And of course, this is familiar. We chopped up the parathyroids. We put them in little pockets in the brachioradialis, just like that kind of pencil drawing that's in some of the old manuscripts. This I told you. And so it was kind of incredible. The patient texted me on day 9 and said it's working because she was so attuned to her hypocalcemia symptoms, like even the very early ones, she just knew. And so we tested her PTH and it was rising. And by post-op day 35, we took her off of all of her supplementation. This is an old slide. It's now been 4 years. So 48 months. So she's had no hospital visits for hypocalcemia since. She runs marathons. She's back at work. She's taking care of her children. It's quite amazing. She is on, so I mean, there's a lot of questions around this. She is on immunosuppression. And these are her current medications, except that recently she went on vacation and forgot her immunosuppressions and didn't tell anyone because we can get it to them for anywhere in the world. But in any case, the endocrinologist has since put her on calcitriol 0.5 3 times a week because her calciums are sitting around 1.97. But again, she's asymptomatic. She's not on any other supplementation. And her calciums and PTHs always, and again, this chart could continue until now. It's the same numbers. They hover low, but she's doing great. There was another case where they implanted parathyroid tissue in the deltoid using a 14-gauge needle mixed with some serum, plasma, or something like that, which was reported before we did our case. And again, I'm not going to go into all of these, but there are some things, some basic science and stuff that's not yet ready for prime time. I think the most exciting might be something like this, macro encapsulation, where there's going to be sort of like a little scaffold where you would put fresh human parathyroid and then implant that and then be able to potentially avoid immunosuppression because PTH would leak out and the parathyroids would be protected. And again, some other stuff, a lot of work on stem cells becoming parathyroids. And this particular paper was quite interesting, basically in rat models, able to show all the characteristics of parathyroid tissue and excretion. And other microencapsulation kind of efforts, putting parathyroid with blood cells in alginate to try and protect it. Again, all of these ways to try and avoid immunosuppression. So that's the story. Thank you so much. These are my colleagues. In particular, Dr. Afshan Zahidi on the right there was the endocrinologist who works very hard on these cases. We have a protocol for now 5 more cases with 2 patients currently awaiting transplantation, and we accept referrals from anywhere, across the border even, and happy to hear from you. Thank you.
Our next president, Dr. Gager, did let me know that he's moderating the next session. So we have to be done by 8 or I'm not allowed in Sacramento. So we'll try to go quick here. I guess one comment I'll just make is John Olson couldn't be here, but it's worth noting that he is studying feasibility on combined parathyroid transplant as well. So hopefully in the future that will be available. A couple quick questions. Saturday, we heard you guys covered everything today. Saturday, we heard a pretty extensive conversation on thyroidectomy and techniques. It sounds like there are some different techniques and different modalities used. Dr. Prescott, do you use energy devices during surgery? Or since you're a Hoden protege, are you clips and ties only? Or how do you make sure the parathyroids survive that?
So I think this is a very important question. Everybody has to think about this if you're doing total thyroidectomy. When I was a trainee, we didn't have energy devices. Everything was tie, clip, and Bovie. As a fellow, nobody used them either. So I did a lot of clipping and tying. Now I use energy devices, mostly because my rate of expanding neck hematoma is 1 and now over 8,000 cases, and I think it's at least in part due to the energy device. I think that that you certainly have to police the use of that device because of the fact that it gets hot, and so where you put it relative to parathyroid tissue is very important, especially when it comes to devascularizing the parathyroid glands, which can have very tenuous blood supply, as you know. So I have not found that it's been related to the use of that instrument, but I'm also very, very careful with it. So I do use that technology.
All right. Another controversy that came up, I'll ask Dr. Khan on this one. There was a discussion for difficult Graves, Hashimoto's, whether or not preoperative calcium regimens are advisable. What would you advise? And I guess the surgeons can comment on what they use in these scenarios.
So for Graves, that's actually an interesting question because those patients can develop hypocalcemia because they have so much bone turnover, but they can also develop hypercalcemia post-op, which is a lot less common. So really for those patients, what I like to do is make sure that their vitamin D is replaced if they need any supplementation prior to surgery. But otherwise, I don't normally give them preoperative calcium supplementation.
All right. Dr. Devin?
I don't.
TK?
Yeah, I do routinely, starting usually 3 days before load with calcitriol and calcium.
All right. Everybody here checks post-op PTH?
I never check it.
Never check it. Everybody here uses Lugol's prior to surgery?
Never use it.
Never use it? All right. So I guess the jury is mixed on this. We had a lot more scenarios to go through, but we are running up at 8 o'clock. So I'd like to thank this committee for their talks today, and hopefully we all learn more on hypoparathyroidism. Thanks.